Okay, so this is how the data flows. So I will kind of high level here. So for the most part, this is the claims data from CMS or any other payer, and then this is clinical information from your EHRs, HIEs, whatever you have, lab vendor, and basically we pull those two together and combine it and do analytics on this. So then that's where your care management, your quality measures, your ACO measures, financial utilization measures, everything comes out of this. And you can interrupt me at any time, Shane. Okay. Now what we've done, this is our first ACO, a pioneer ACO that we actually we turned on May of last year. And they use Epic. So this is how they actually want the data displayed. The three ways the data can be displayed. We can push the structured data into your EMR. We can push it into a portal, the IGI portal, or we can just display the patient level data. Franciscan, they wanted us to push the patient level data. That's the last drill down with gaps in care, quality, everything. And that's how they've done it. And so they actually built a banner on the Epic EMR, we'll call it ACO Link. So if a provider is in the office seeing this patient, kind of tells you this patient is an ACO beneficiary, you click on this banner.
Well, okay, I'm sorry, back up a little bit, back up. So what I'm looking at, is this your system
ACO,
or another?
Some of them they don't want to change the provider workflow.
Yeah, right. I got it. So yeah, I got that. So, but the ACO link, how did you get that? How do you know that this patient, when they present, is part of the ACO? How did that show up there?
So the organization built that, so they know who their ACO beneficiaries are. And
okay, I got it.
Create an ACO link.
All right.
Right. Some other organizations have like ACO, yes or no. So then anyone on the ACO says yes. So the different ways of displaying it. Does that make sense?
Yeah, I got it. Okay.
All right. So if they click on this, what they want to see is exactly this. This is now advances. So it pulls up this display, what we call it member dashboard. But basically all that gives you is, this is the basic demographic information, care management programs that the beneficiary is enrolled in automatically. This piece here is predictive modeling score. So we run predictive modeling analytics on the whole beneficiaries and normalize it. So for an ACO, say Atlantic, if you had 20,000 beneficiaries, the average is going to be 1.0. So this person now will, what you will get from
this, they click on that. So they click on that link, and it basically launches your application, and you must be passed in whatever current patient they're looking at, correct?
Exactly. So, and that's where IGI does that for us, actually. They do that single sign-on. And maybe you want to talk about that, Tom, briefly? Oh, but I want to do more because this is an ACO patient. So all I'm doing is I can document all I want in my EMR like I normally do, but I want to see, I don't have claims data from CMS in my EMR. I don't know how many times the patient has been to the emergency room. I don't know what the cost is. But Advances has that. So what I do is I just click on this link, and it gives me more information than what I have in my EMR. This information right here is coming from my EMR. It could be coming from HIE, or if we have 5 EMRs in my system, we're aggregating all the clinical data and displaying it to you, Dr. Smith, who's seeing the patient today.
Right, but this, what I'm looking at, is specific to the patient that I was just on in Epic. Is that correct?
Yes.
Okay.
Exactly.
Okay. So
you don't need to log in again. That is absolutely correct.
Our engineers built that back end, Shane.
Yeah.
Seen the program.
They can look at how sick the patient is. That's basically all this tells you. For care management, the care manager's notes, I can read it. And again, this is critical value depending on how your ACO is set up, because some ACOs they have multiple EMRs, they don't talk to each other, and we build that interface and pull all that data and the source. This says live here, but typically we'll put the source of the data if it's one hospital, St. Barnabas, another hospital, whatever, and it's all listed here. Then these are the gaps in care. So looking at this, the provider can actually tell that this patient hasn't had an A1C, or if they had an A1C and it's not within goal. They can tell just by looking at the screen.
Yep.
And we're not just combining clinical, we're also using claims. Granted, this is not an ACO measure, but the claims data we use to close gaps too. EMRs don't have, for the most part, don't have claims. So the provider may say, well, I already have a clinical data. Why are you showing that to me again? Well, we're showing that to you so you won't be clicking multiple tabs in your EMR, trying to figure out when that patient had an eye exam, or trying to figure out when it had an A1C. We're basically telling you, focus on this, and don't have to worry about all that. It improves their workflow, basically. And I don't know about Atlantic. You guys have multiple EMRs, right, Shane?
Oh, yeah.
Okay, all right. They can do e-prescribing, and they can basically do a lot of the stuff that they need to do right here. And we also have a content, patient education content built into the into this portal. So let me open up this patient here. Okay, so what we see here is just basic information that you see in most EMRs. But the key, and I'm just going to focus on this one, is the dashboard. So we build this tab here in the portal is the same functionality that we built in the EMR. So you got two, patient and provider dashboard. Let me just spend a little bit more time on the patient dashboard here for a minute. So again, functionalities. So right here, we give the providers the ability to see how much was spent on that patient in 3 months, 12 months, number of PCP visits, specialist visits, ER visits, and hospital bed days. This is 12 months, so every report here is rolling 12 months. It's updated monthly. They can look at the cost by diagnostic group, medication if the patient is signed up for Part D for ACO. And then at the bottom here, they can also see like diagnosis and how many times the patient we've had a claim for hypolipidemia, basically saying, hey, this patient was seen 3 times in 12 months for hypolipidemia. So that's useful information too. Then they can also do a drill down on the encounters, the number of visits. So it says, again, on top here, it says 3 and 12. This is really what's driving that. It's right here. You can see what that patient saw, the provider, the specialty and diagnosis, the labs. You don't see the value here, you see the value on top. But this is all claim-based lab, and then the medication the patient is on. Okay, so this is a drill down, but the summary kind of gives you an overview of everything. Now on top, and they have access to this, the care managers in the office, the practice can actually do care management on this same tool that we're displaying in their EMR. So the assessments all reside in there. Okay, so the assessments for care management reside there. They can add supplemental data. So for example, you're seeing a beneficiary who had a mammogram at a free mammography place, and you don't have claims, CMS didn't pay claims, and you don't have anything. You know that this patient actually had a mammogram somewhere else. You can come in here and actually put in that result. It could be the office, it doesn't have to be the provider. Put in a result in here, and it will close that gap. So this is where this is a supplemental data entry, which closes gaps. Pause for a second here. Any questions?
No.
Okay. So again, this is a tool. Now I'm going to switch to the provider dashboard to show you what the providers actually see. So this is this provider's dashboard. We look at the total population, the beneficiaries assigned to this provider, 324. We know what the primary diagnosis for each patient is. And we know what the average cost for that diagnosis is in our system. So we come up with what we think is an expected cost for that panel of patients, maybe $1 million, for example. if that provider ends up at the end of the year, 12 months, the cost is lower, that provider is more efficient. And then we rank that provider for that specialty. So this happens to be a family physician. She's ranked at the 70th percentile. Someone is going to be at the first percentile, and someone's going to be at the 99th percentile. So it's really just tiering your providers so the chief medical officer or medical director can see who they really need to spend some more time with to make them more efficient. Obviously, the ACOs cost is one thing that you need to be tracking. And this is what's driving that report I just showed you. So you would break down the cost, professional, facility, and pharmacy, and we'll come up with an index. This provided its average. But one thing that you look at here is the severity index. Most providers will tell you my patient is sicker. And this you can tell, yes. Providers, patients, that's sicker than the average.
So you'll weight it against their patient acuity?
Yes.
Essentially? Okay.
Yes, exactly. Exactly. And let's skip down. This is coding, which may or may not be that important. And ER utilization for that provider. And we actually also look at the number of ER visits that were non-emergent, considered non-emergent. And that's really based on coding. You know, so and anything that's on the line, there's a drill down. So for example, if I were to look at this 8 ER visits, the first patient here, apologize for this, they were supposed to take care of that little thing here. Been to the ER multiple times. We can actually, there are always 2 claims, one from the ER doc and the second from the facility. So that's why you have 2. Okay? So there we go. In descending order, we'll list the frequent flyers so the providers can actually see. This is information that most providers don't even know who's going to the ER and what for. The bed days, admits per 1,000, the spillage out of network. So when we bring on ACOs, they tell us what facilities are in network for them, you know, and then anything that's outside, that's what they can tell what type of spillage they have, you know, folks going to their non-owned facilities. This is the ER utilization for this doc.
Oh, so I'm sorry, back up. When you say utilization outside of, go into that a little more. So you're saying that you're tracking if they're using sources outside network?
Yes. 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 So we know if they tell us, that's what we have to do some. They got to tell us who's in network and who's not. And so when we implement this, so Atlantic Care, what's your main hospital, Sean?
Morristown.
Okay, Morristown. So anything, if they go to Trinity, this is how much was spent. This is the average for the specialty out of network, family docs. Yours is higher. There's a reason why. Probably because your patients are sicker, or maybe it's just one patient who was admitted somewhere for months.
And I'm assuming this is probably from claims data, I would assume, correct?
It is. Yes, it is claims data. Absolutely right. It is claims.
Okay.
And then this is emergency room utilization. The benchmark is that specialty. So this is all the family docs in the system. This is the average, and this is just doctors. And generic utilization. And the care management. So doing care management, we know care management is critical to the success of any ACO. So the care managers, the system is all integrated. When the care managers are doing care management, the providers can actually see who is in care management and who is not. By clicking on this, they can actually get the same information I showed you earlier on that patient.
Yep.
So generic utilization. I'll skip through some of this, just give you the highlight. This is advanced imaging, so MRI utilization. We can tell what your MRI rate per 1,000 is compared to your specialty. And we can also tell you which one you ordered and which one was ordered by someone else. So direct were the ones that were ordered by Dr. Alkis, and the blue were the ones that were ordered by other patients other providers who are seeing the same patient. We do the same thing for CT scans. And then this is the outlier report. This is the sickest of the sick of this provider's panel. And mind you, we have the same report for the whole same organization. So everything I'm showing you here, we have it for the whole ACO. But looking at just this provider, the provider can actually tell who her sick patients are. So for example, this patient here, Mr. Leonard, obviously is having chemotherapy. He spent $114,000 in 12 months. And this provider can come in here and do a drill down, and that drill down will give that provider information on this patient.
So, I mean, this is a huge amount of information, and how is the physician going to actually use this? What?
Right. So let me tell you. Right. So let me tell you.
So if I'm in, you know, are they going to have to go and they're working in the EMR doing documentation? If they want to know information at the point of care associated with a particular patient, do they leave their system, log in here? What are they actually doing?
No. So at point of care, it's that, remember that ACO link I showed you, and when I clicked on it, it displayed that dashboard? That's what they need at point of care. They don't need this. This is mainly when the medical director of the ACO targets certain providers who are not performing very well and will sit down and do an analysis of what's happening.
All right.
Yeah. Does that help?
Maybe I missed that. So you're not looking at, but there's information in here that would be useful for the physicians to know. Well, you showed it to me earlier, especially if they're looking at tests that might have been missed, i.e. the A1C, if they're diabetic and they haven't had one in 6 months, that type of thing.
Yes. That's what they need at point of care. They don't need this at point of care. They would not even want to look at this when they see.
Yeah, got it. Okay, all right. I just was confused. Fine.
Yeah. Yeah. So, and then this is the dashboard for that provider. So they can actually see, well, you know, my patients aren't doing very well. My A1C, not A1C, my breast cancer screening, you know, isn't as good as my peers, for example. And what am I doing wrong? Or and maybe my medical assistant. I think this is really where you look at what incentive, how are you incentivizing your ACO docs to get your numbers up, right? So you got to look at a dashboard for that provider. This information gives you some of that reporting. So the provider can say, well, maybe I need to spend more time getting all my patients who come in for a cold who need a mammogram, have someone do a mammogram. Or maybe my medical assistant can go in and pull that information. I don't have to be doing it myself. That information is out there.
Okay.
So, yeah, I think I'll skip this. But this is the provider dashboard. They can actually even look at their cost trend. You know.
Right, so the medical director of the Barnabas Health System ACO is very interested in this to do exactly what Anthony was saying, to have that conversation with the doc, talk to them about a few of those KPIs, and if nothing else, the Hawthorne effect takes place, right, Shane? You know, these people know that you're watching, so just by virtue of the fact that you're having the conversation, things start to look better. You need to do much more than that, but just by virtue of being able to have that conversation because you've acquired the data does help.
So this is a report where it actually gives you the bottom line. This number obviously is not a Medicare ACO. It's too low for that, but it will give you a PMPM for your whole population and compare it to prior year, and then give you the total spend. Then it also breaks it down by pharmacy, professional, and facility. And you can also do like a drill down on anything here. So you might want to say med-surg. You want to look at the facilities where these patients are going, the CPT code, and so let me just do CPT code. So you can do a drill down and figure out what's really driving this. Then there is a utilization report here. There's so many reports, but I'm just showing you the ones that I think are very important. So the utilization report, let's just choose something that everyone looks at, emergency room utilization. So just looking at this, we can do the same drill down. what's driving the emergency room utilization? The providers. Frequently,
is this again? This is coming off. I mean, this would all be coming off of claims data, I would believe, right?
That is correct. That is correct.
And
Shane, we do collect all three dimensions, right? Dr. Acosta gets quality data extractions from
right.
and that's manifested in certain types of reports. And he gets the clinical feeds, the results and lab results, and obviously he gets a lot of claims data that he uses.
Right.
Quite
Right. Well, I mean, I'm assuming that all of the stuff that is showing CPTs and finance is going to come off claims.
Right. That is correct. And the quality.
Is this, I'm sorry?
Go ahead. Go ahead.
No, is this driven off of your HIE and you're using your HIE as the data aggregation mechanism? So if an entity has an HIE, how are you going to implement?
If they have an HIE, that really helps. The critical part of that is more the quality metrics and care management. So with the HIE, so a typical example is we know the patient had a cholesterol because CMS, for example, paid for it. We know there's a claim for it, but we don't know the result. So
right.
That's where the HIE will give us the result. We use that for our quality initiatives, and they use that for also care management.
Okay.
So with HIE, you got redundant data. So you know you got claims and you got HIE. So which one do you use? For this report, this particular report that I'm showing you is claim-based. The care management reports is both. So it kind of depends on the report that you are looking at.
Okay. All right.
But you know, Shane,
yeah.
Shane, we run an HIE, right? So transport of data is something that we would use the HIE for. So right now, all we need to be able to run an ACO effectively is, the clinical feeds, the results that come from all those disparate systems. But in the future, you think about how you can include, doctor's notes or visits in the ER, things of that nature, or being able to deliver the analytic content to those endpoints is something that I can see the HIE being able to transport.
Right.
All right. So, I guess emergency room levels, here you look at the rates per 1,000 for that population, and you look at your total spend, $3 million, ER visits, and the only thing that you look at is your unit cost. It may not matter for an ACO because you have the same payer, so there won't really be any variation in this, but there will be variation in the rate, the utilization. And those slew of reports, I'm not going to go into all of this. Then the other thing that we also can display is some hospital utilization information. So you can tell your bed days per 1,000 with prior 2 years stacked up against each other, and then you can look at length of stay and admits per 1,000. So this here is highest cost patients summary. So this first person will be your highest cost beneficiary, for example. And it tells you the professional cost, facility, pharmacy, total cost, and then ER visits. And you can do a drill down. Obviously, this is not PCP specific. This is organizational level. This is where the medical director will probably be the one looking at this. And you can tell just by looking at this what's really driving the cost for this patient. This patient has been in hospital for 19 days, and all that information resides here. And the other thing that I'm just picking up information here that I think might be useful is ER utilization. So your frequent flyers, like I showed you earlier, was for PCPs. This is for the whole organization. So this person has had 10 ER visits in 12 months, was admitted once through the emergency room. Then we have, this is the care management platform. This is where the care managers will log in, just like we have where the providers log in. This is where the care managers will log in and do care management. I want to pause a little bit, Shane. I want to actually see, there's so much information I can show you out here, but I want to see if I can show you what you're really interested in seeing today and answer questions.
Well, I mean, it was really just an overview to give me some familiarity with it generally. So, I mean, so this is fine. I do want to be conscious of time. I know we're scheduled to go to 12:30. If we could wrap up just a couple of minutes earlier, I would appreciate it, as I've got a call right after this that I need to do a couple of things for. But what I was really looking for, again, was just an overview. I am doing some work out at Atlantic. I know you guys have talked with them, and if there's anything that I can do to help that cause, I certainly will. So being able to speak to this a little more intelligently is really what our goal is out of this.
Good. Shane, I want you to know that there's two other operating processes that we collaboratively have been working on, right? So one of the things that happens with these ACOs is address matching and processing, right? That all of the files that come from CMS, we process, we load, we analyze, we integrate, we do all the backbone, right? We also find addresses in batch. So for Barnabas, for example, we have found over 5,000 addresses over the north and central regions across their 25,000 beneficiaries because they were having trouble doing that. So we do that. We also do the consent tracking where patients opt in and opt out of the service, and that's coordinated with the mailers that go out. We do the mailer. We do the whole piece of that too. So sometimes I'm telling you that those become opportunities to maybe get in on the ground floor, do some operations things that then lead to other opportunities. You follow?
Yep, got it. Mm-hmm.
All right. So keep that in mind. Let's touch base when you get a chance. Give me a ring and let's talk some more.
Absolutely.
All right.
Yeah. I think I would. This is an overview, so there's really I don't want to spend a lot of time showing you anything else. So
yeah.
I don't know if there's any other questions you have for me, Shane.
No. I mean, it looks like a very, very comprehensive set of tools, and I'm sure it can bring a lot of value to these organizations. I'm trying to connect what you've shown me with what they're doing in the operation. So you've got the users of this information would be either the physician at the point of care where they're looking to see if a particular patient, what those quality measures are for that patient, right? What do they need? Do they need an A1C? Do they need a mammogram? So on and so forth. Then you've got the administrative component on the back end, which will essentially support the operation of the ACO from a financial as well as a quality perspective. So that's what I see. That's what you're doing, basically. Is that a fair statement?
Yes, that is correct. Right.
Absolutely. So all the different components in the operation at the point of care in the practice can be supported and workflowed out with the tools.
Mm-hmm. Yeah. I mean, I think a challenge you might have is these clinicians at the point of care are overloaded already, and they're not really interested in getting another system that they have to use. Doesn't mean that you can't force them to follow the operation, but it's going to be a bit of a hurdle, right? So
I think for me, Shane, I'm a practicing physician today, and I've done a lot of this demos to physicians from multiple states, and I would tell you, we struggle as physicians to get this information. Where I practice, which is an ACO, which is competes with some of my owners, we don't even have this, and I'm praying that they can actually come up with a solution like this. So I think that's why we came up with that single sign-on. It actually improves their workflow. It helps them. Most providers who see this, they get it. So I don't see this actually impeding them in any way.
Yeah.
And it's all, Shane, about how you deliver it. So maybe the portal is the conduit for the nurse practitioner to kind of tease it all up. Maybe the workflow that way needs to point in that direction. Or maybe it needs to go to the mobile application somehow. You know, those variables, and you've seen one ACO, you've seen one ACO, right? I mean,
Right.
Barnabas is taking the approach that, look, what we're going to do is we're going to launch the portal. We're going to provide content and education to the providers. We're then going to migrate into, you know, the information that we want them to go there for, because they have to transact a lot of PHI with these physicians. On top of that, they're going to have a logon that serves the PA or the nurse or the person that works for the doc, because in some cases it might be a simple printout. You print out the backup, the knowledge that you have about that patient, and now they go and they fill it in their EMR and they're done with it, you know. So there's different ways to skin a cat, Shane. It's not a one-stop, you know, I'm not trying to punch it into a hole in the wall.
See, Tom, I think, Shane, what you told me about having multiple EMRs, see, because you kind of think about it this way. If a patient has gone to multiple hospital systems, multiple hospitals in your system and seen multiple docs, that information, so when that patient sees the doctor, but yesterday saw someone else in a different system, they wouldn't know what the patient, what test was done. What would they do? They'll order it again. So, but displaying that information to them at point of care, they can actually tell that, hey, you went to this ER yesterday, you went to another hospital 2 weeks ago, and I can see all that information, a longitudinal view of everything you've done at point of care. That saves the doctor's time.
Mm-hmm. Got it. Yeah. No, I see it.
Right. Well, that's the overview. I think there's more to it. Usually this takes a little over an hour, but what you wanted was just an overview. So if you have any questions.
Yeah. No, I've not seen it specifically like this, but I'm kind of familiar with it. So it's definitely you've definitely done a good amount of work on this. Yep. Yeah, Tom.
Shane, I'm curious. So you've seen, and I know you a long time, you know, good, better, and different. You've seen a lot of different things. Talk to me about how we differ, how it's different. What pearls of wisdom can you give me?
Well, you know, and I don't mean to, because so many of these solutions are all trying to solve the same problem.
Right.
They quite frankly look pretty similar.
Okay.
And the variance between them is really more on just the interpretation of how the information is presented than necessarily the information itself. I think you have some really nice components to it. When you look at the utilization over a particular norm, right? That's going to the cost component of it. You seem really strong in the analytics around some of the cost analysis, which when you're looking at an ACO, that's going to be very, very useful. Very useful. So I don't know that I'm giving you a lot of specifics out of this. If you want something more specific.
No, that's cool. That's good information, because you know what? I know that there's 50 people calling Atlantic a day, right? We know that because we've done an assessment, and we've contacted every ACO, on the Northeast. So
right.
We have a good idea of what people are doing or buying and how they're being harassed. So you got to find differentiators or a friend inside that can help you have the conversation. One
Absolutely.
differentiator that these folks have is they've been doing it from the beginning. Dr. Acosta's been in the ACO business how long, Doc?
Oh, it's been before anyone even knew what ACO was, so almost
Right.
more than 2 years.
How long?
Right. So
more than 2 years. We started up before with a Pioneer, 2011. Matter of fact. Yeah.
Yep. Yeah, which Pioneer was it?
Which Franciscan Alliance?
Okay.
Mhm.
Yeah. I did
So
work
Shane,
with Pioneer ACO down in, you knew that, down in Dallas. So.
right, so you worked with one of those too. So
Yeah, it was Karen Care.
Yeah. Okay.
Karen Care.
Yeah, Karen Care was the payer.
So experience is something that I think is a differentiator because analytics are analytics. Shane, you're a developer. If you wanted to, you can write this stuff, right? The difference is that when Dr. Acosta talks to our, and it happened with Barnabas, when he talks to them about their pain points, he knows what they are, and he knows how to respond to the questions because he's been there, done that. I believe that's a big differentiator because you're right.
Yeah.
They're all trying to solve the same problem. The other thing that I'm finding based on our assessments is, the 3 dimensions of data, right? A lot of people just do claims,
Yeah, but
transforming
you can't just do claims, and that's part of the issue. I mean, claims one are fairly prospective, and still the accuracy can be somewhat dubious. But anyway,
right. But you need to be able to have
not prospective, retrospective. Sorry.
correct. So he's also working on a clinic, and so he supports 5 MSSPs, including Barnabas with me. We're partners, and 1 Pioneer ACO, and he's also working on a clinical integration project in a large health system in Chicago. So moving the data, turning it into knowledge that people act on is something that we all have experience doing. So I think that's a differentiator because you're right. They all look very similar.
Right. So Shane understands technology. The latest thing that we're actually doing today is putting data capture tool in practice management systems. That's what Tom was talking about, clinical integration. I'm pulling claims data, pre-adjudicated claims. We're pulling it into our data warehouse and using that for population management. So we're not even waiting for claims to show up. We're not even waiting for providers they're billing out of their practice management. We're knowing who the diabetic is. That's the latest thing that we're actually doing.
So you're not waiting for the claim to come back from being paid. You're actually doing it. You're grabbing the HCFA 1500, I guess, before it even goes out. Is that?
Yep.
Yeah. Okay.
Yeah, that's the latest thing we're doing, and we have to do that for clinical integration so there won't be to pass FTC muster. They had to do something like that. So they can use clearinghouse to get claims, but they wanted to go a different route and pick it up right away the same day. And
you're basically getting it at the point at which the practice actually compiles the claim before adjudication. So you're going to be ahead of the game by 30 days or some number.
Exactly.
Correct.
Right. And we've already invested in that tool, so whoever uses it is going to get a lower cost because we've already done that investment. We already licensed it. We're using a tool called Recombinant. Now, Deloitte just purchased a few, just to drop the company because they saw the value in that. But we already have a license, perpetual license for that tool.
Right. So the prospective view is very important too, Shane. You get 30 days ahead.
Absolutely.
At least.
Yeah.
So everybody tells you they're different. That I think that we have a good story to tell, and I tell you, Dr. Acosta and his team, whenever they get in front of these folks and they start talking hardcore operations, and you can ask Woodward, right? Because he was very impressed with Dr. Acosta's product and when we did the demo. So I think it's a huge opportunity.
You've got you have a very comprehensive product. There's no doubt about it. The issue becomes these things can be so comprehensive as to be overwhelming, and you don't see the forest for the trees kind of thing. So it becomes a little daunting, frankly, in terms of how do you actually differentiate one from another, because there are so many points onto which you could analyze any of these that it just makes it a very, very complex process.
That's a good point. I agree with that. I think the challenge is, like Tom said, analytics is a dime a dozen. It really is. Everyone is jumping into this.
I tell you, every freaking buddy in there, and you know this, everybody and their brother. I mean,
Yep.
it's like a free for all.
Mm-hmm.
Oh, it is. It's a gold rush. We
It's
absolutely
a
know.
gold
We're in the,
rush.
Yeah, but the
Huh?
problem
It
is,
is.
yeah, I think what differentiates us, quite honestly, is that support. So basically, initially we started as we're a health plan. Care management is our core competency, really. So I think what differentiates us is not those products, it's how we can actually support you. Because we can do care management, we can train your nurses, we can, we have the skills. So that's really what differentiates us from all the sort of vendors out there.
Right. See that to me is absolutely a differentiator, because the real issue with so many of these systems, it's not so much about the system. That's great. Yes, you can have that software, but if you're not able to put the operational processes around it in place in order to effectively leverage and drive information to it and from it, and then actually drive changes in behavior on your providers and your providers, both physician and nursing, it's not going to do anything, right? And you've got to come in with a package which addresses both operational issues, if necessary, as well as the technological issues. I mean, a lot of these places, they may say they have it all covered, right? Everybody thinks that they can do everything themselves, but the operational issues are to me, what can make or break the success of some of these ACOs. And again, I mean, it's not the only thing we do, so it's not like I'm in the ACO world every single day, but it does seem to be something that I see. So to your point, I'm just echoing what you said, that yes, it sounds like what you have in terms of other capabilities can add a lot of value to this core system.
and you know what, Shane? Because I'm going to ask you to open that door, and when I ask you to open that door, what we're going to do is we're going to come in with the right story, right? So if we sit down and we have a discussion about, what are those operational efficiencies that Atlantic needs to adjudicate, we'll make sure that we come prepared to tell that story, right? It's all about the story, because I'm confident that we can deliver. I mean, it's what these folks do.
Now, you should know, and I don't know if you're aware, I mean, Atlantic they're so in bed with McKesson, right? They don't do anything outside of McKesson.
Yeah.
I
know.
And McKesson, I mean, I'm doing a lot of work with McKesson. Honestly, I've never seen something so bad. I'm completely and utterly flabbergasted at how horrible of a system that is. But I probably shouldn't be, and meaning surprised. So I hope you guys aren't McKesson, fans.
No, we're agnostic. We have to connect everything.
We are agnostic, honestly, the truth, yeah. Because our clinical integration entity, they use McKesson and they complain too. But we built an interface for it.
They're horrible. It's absolutely horrible. So in any case, so I know that McKesson just bought a company called MedVentive.
Mm-hmm. Yep. Oh.
Yeah.
That's bad too.
What's that?
You're laughing?
Yeah, that was the company out of Boston, right? I mean, I actually talked to them. I got an introduction to Nancy Ham some time ago, the former CEO. She left. She's not there any longer. I guess, when McKesson bought them, they booted her out. But I don't know a lot about that system. I've heard, varying things about it. But because it's a McKesson product, I know that Atlantic is talking to them, and it's going to, quite frankly, be an uphill battle. So I haven't really poked around, but I can do that. I'm going to be out there next week, and I'll ask around and say, well, what's going on with this?
Listen, I know I can be cheaper.
Yeah, that product is not well. I mean, I know a lot of ACOs that were using it and they had to abandon it because it wasn't doing what it promised to do. So.
Yeah.
Hey, so Doc, Anthony, if you know who those people that abandoned it are, that would be great intel.
Yeah, that would be great intel.
because that would open the door for us to say, hey man, look, we got the Barnabas deal away from QualCare. Shane, that was hell to pay. All right. Remember, Barnabas owns QualCare. They're the largest owner of QualCare, and we were able to win the business because they couldn't show what Anthony and his team could show. So I just need the entry in to tell the story, and that's all I can ask for, right?
Yeah. So
well, I'll ask you for more because I know you, but
Yeah, Atlantic, and again, Atlantic, I think has some relationship with QualCare, so it's kind of interesting.
It is interesting, but why would Barnabas, the largest shareholder of QualCare, decide to go with little old us, right? I'm telling you, there's the secret sauce here. I just want to show it to him.
Yeah.
All right.
Well, so I need to, Tom, why don't you and I get on the phone early next week, and we'll talk about some next steps, okay?
All right. Thank you, Dr. Acosta. Thank you, Shane.
Yeah, Tom, can you and I plan on catching up like late Monday?
Yeah, sure. Absolutely.
Okay. So I'll have a conversation between now and then with some, just inquiring so I can have a little more information. But let's touch base Monday, if not then Tuesday, but we'll definitely have a conversation. It looks good. I appreciate your time, guys.
Okay.
All right. Take care, Shane. Thank you.
Great.
Thank you, Doc.
Thanks.